Welcome to the conference session titled Understanding Aplastic Anemia. Thank you for joining us. My name is Alice Hauk, Senior Director of Patient and Professional Services at AAMDSIF, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help us manage the incoming questions. First, submit your entire question all at the same time. And second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Dr. Daria Babushok. Dr. Babushok is a physician scientist and an assistant professor at the University of Pennsylvania in Philadelphia. Dr. Babushok earned her medical degree and a PhD in cellular and molecular biology from the University of Pennsylvania. She completed her internal medicine residency at the Massachusetts General Hospital, followed by a hematology oncology fellowship and a postdoctoral fellowship in hematopoiesis at the Hospital of the University of Pennsylvania. Dr. Babushok's research and clinical interests focus on the development of acquired and inherited bone marrow failure, disease progression, and malignant transformation, and improving treatment in patients with bone marrow failure. She is also a past recipient of an AAMDSIF research grant. Welcome, Dr. Babushok.
Thank you so much, Alice, and it's a true pleasure to be here today. Let me share my screen. So I hope all of you can see my slides. So the presentation today will be to discuss the basics in the diagnosis and treatment of aplastic anemia. So whether you're joining me here today, having been newly diagnosed with aplastic anemia, or whether you have been on this journey now for some time, I would like to start by bringing everybody up to speed and giving some basics, both about the blood cells, bone marrow, and general bone marrow failure. I will then discuss how we diagnose acquired aplastic anemia, and then we'll review aplastic anemia therapies, both the transplant side and the immunosuppressive therapy side. And then we'll touch on about the long-term follow-up. So first, the basics. Acquired aplastic anemia presents when patients have low blood counts. So what are the blood counts? We have generally three blood lines. We have white blood cells, platelets, and red blood cells. When the patient with aplastic anemia comes to the physician, they may experience, for example, fatigue from low red blood cells. They may have infections from low white blood cells. White blood cells are our immune cells. They come in different flavors. There are the neutrophils. These are the immune cells that you may recognize as forming pus, for example, when they respond to bacterial infections. When that neutrophil number is low, your physician may say that you're neutropenic or that you have a low ANC. ANC is an absolute neutrophil count, and you would have this on your blood test results. Neutropenia is basically a term for a low neutrophil count. If you're neutropenic, you're very susceptible to infections, and special precautions may be taken. When we have, another type of white blood cell are lymphocytes. So lymphocytes are very important immune cells that help us fight infections such as viruses, or for example, molds or various other infections. But in aplastic anemia, it is the lymphocytes that attack the bone marrow, and they are the ones that are thought to be the cause of aplastic anemia. Red blood cells, on the other hand, carry oxygen. So we can measure them as red blood cells. We also sometimes refer to the condition when the red cells are low as having low hemoglobin or having anemia. So the low hemoglobin may make you feel tired or short of breath with activity. Sometimes it's difficult to tell why somebody is anemic. For example, you may be losing blood if somebody is bleeding, for example, for a different reason. So it's very important that we also look at the early red blood cells, and those are the cells that your physician may refer to as reticulocytes. Finally, the third type of bloodline are the platelets. So the platelets are our clotting cells. And so if somebody has low platelet count, it is referred to as thrombocytopenia. So somebody may say that you are thrombocytopenic. And when those platelets are low, you may be more prone to having, for example, bleeding, bruising, or having this little rash called petechiae. All of the blood is made inside of our bone marrow. So it's made inside of the bones. And you can see here, for example, on the graph, this would be a diagram of our long bone, and the stem cells and the early progenitor cells are made inside of the bone in special environment called the bone marrow niche. So inside of these areas, inside of the bone, the little spots, we have the stem cells that set up almost like little factories, and they make the blood that then circulates through our whole body. The only way to determine what is happening as a bone marrow inside of the bone marrow is through the use of a bone marrow biopsy. So that is why your physician may have very quickly recommended to get a bone marrow biopsy, which is basically a procedure that you can see where the needle is passed through the cortex of the bone, and a little sample is taken to look at both how many blood cells there are there, how many of these early hematopoietic cells, early stem cells there are, and also what types of cells may be missing, or if there's anything else that shouldn't be there that is there. Now, as I mentioned, when a patient with aplastic anemia presents, they may present with low neutrophil count, low hemoglobin, that's the red cells, and the low platelets. And the symptoms are really caused by these deficiencies. So for example, if somebody has low neutrophils, they may have had infections or fevers. Somebody with low hemoglobin may be getting short of breath when they walk very short distances, climb stairs, have no energy. And then similarly for the low platelets, they may be having, for example, for women, heavy periods, or they may be having those little petechiae spots of little bruises. Now, when this happens, the physician then your doctor may then refer you to a hematologist, so a specialized doctor who sees patients with blood disorders, and a bone marrow biopsy may be performed. And so this is an example of what your doctor may be looking at when evaluating a bone marrow biopsy. So on the left-hand side, we see a normal bone marrow biopsy from an individual in their middle age. We can see these white areas. So these are essentially the areas replaced by fat cells, which is normal for us to develop these as we age. And then in between, you see the areas with the pink and the blue. So these little blue areas are actually early blood cells. So these are stem cells and their progenitors that are making blood in your bone marrow. Now, in contrast, when we look at the bone marrow biopsy of somebody who has aplastic anemia, first of all, if you can see at this red area highlighted here, we see that almost the totality of that area is replaced by fat cells. So that is not because somebody is fat, it's because of the normal reaction of the bone marrow to the absence or the deficiency of our stem cells to replace it with these cells. And then you can still see in some areas, there may be little patches that are still trying to make blood. So this would be a deficiency of stem cells inside of the bone marrow. Now, when this happens, when somebody has low blood counts, in conjunction with having too few cells in the bone marrow, or so-called hypocellular bone marrow, then a diagnosis of bone marrow failure can be made. Now, bone marrow failure is just a term. So for example, you can think of this as somebody having, let's say, kidney failure or heart failure or liver failure. here we have bone marrow failure, which just means that the bone marrow cannot do its job. It cannot produce enough blood cells to sustain normal life. But it doesn't mean that the diagnosis of aplastic anemia has been established, because bone marrow failure itself can be caused by a number of different things. Some of these are obvious. For example, if there is some, let's say, exposure to radiation that can cause bone marrow failure, or infections, or inflammatory disorders, autoimmune disorders, for example, very rare vitamin deficiencies or myelodysplastic syndrome, or a variety of things can cause it. However, these, for the most part, can be excluded relatively quickly. Then a large number of patients will have none of these causes that are readily apparent. And so they will be sort of called as having idiopathic, sort of aplastic anemia for unknown cause, and the majority of these will be immune mediated. So autoimmune aplastic anemia, which is what will be the focus of my talk today. Now, it's also very important, and particularly in younger patients, pediatric patients, but also adults, also young and even middle-aged adults, to exclude congenital causes of bone marrow failure, which can be caused by genetic mutations that lead to malfunctioning of the bone marrow. And the importance, the key part to remember is that a different cause may have different treatment. So you can imagine, for example, if somebody has a vitamin deficiency, well, we would need to replace the vitamin. If they have an autoimmune aplastic anemia, then that cause has to be addressed. Or if somebody has an inherited disorder, then the treatment also would be quite different. So once then the diagnosis of bone marrow failure is made, and once a diagnosis of aplastic anemia is suspected, there are several steps in the evaluation to really nail down the diagnosis, to make sure that that the aplastic anemia diagnosis is correct. So at the outset, I would strongly recommend that if you're, for example, at a smaller center that does not see patients with aplastic anemia routinely, that your doctor would be making a referral to a center that sees patients with bone marrow failure and aplastic anemia. Additionally, there may be very sophisticated supportive care that is needed, in addition to providing, let's say, transfusions that can be needed even weekly or several times a week, sometimes if somebody has a really severe aplastic anemia. Once that referral is made, an evaluation then starts up, and there's exclusion of all of these causes that are easy to fix, sort of called transient causes, as I mentioned. So usually a panel of tests is sent at the same time, trying to expedite the diagnosis. So you might be having a lot of blood taken for various tests, making sure that you don't have infections, or that you're not missing some vitamins or something like that. Additionally, for those patients who are younger, or even young adults, or even middle-aged adults, there's also frequently an evaluation that's needed to exclude some of these congenital disorders of bone marrow failure, and that can take a few weeks to do. However, I'll mention here that we more recently identified a couple of lab tests that are a little bit more specific for aplastic anemia, and they may allow a shortcut to the diagnosis. This is not by any means, this is not to say that if you don't have this, that you don't have aplastic anemia, but it certainly can provide sometimes a means to expedite the diagnosis, because about 50% of patients may have these findings, such as PNH clones or 6-PLOH. So your doctor would know about these, but that is something that can be tested. And if it's present at a high degree, then it usually suggests that probably it's an immune-mediated cause. So in general, aplastic anemia is very rare. So in the United States, we have approximately 600 to 900 cases per year, per average year. Now, that is because the general worldwide incidence of aplastic anemia is about 1 to 2 cases per million per year. And that varies a little bit between the different ethnicities and racial groups. However, aplastic anemia really can be found in anyone. So individuals of any age, sex, race, ethnicity, any geographic location can get aplastic anemia. And As far as the age is concerned, so it's certainly can be seen in kids. So there's a peak of aplastic anemia in adolescents, and then also it can be seen throughout adulthood. And then there's a second peak in the elderly for developing aplastic anemia. Frequently, patients may wonder, what caused it? Did I do something wrong? Can I do something to fix this? And in most circumstances, we cannot really pinpoint the cause, sort of the one event that caused the aplastic anemia. But I think it's a constellation of factors. First, there are certainly some genetic differences that can make somebody a little bit more likely to get aplastic anemia than an average person. So these may be different changes called polymorphisms in several genes, for example, genes for our immune presentation, but also, and also there may be other rare inflammatory conditions that are also linked to aplastic anemia. So some patients, for example, develop aplastic anemia right after they develop this autoimmune hepatitis. But again, that is quite rare. More recently, we have seen that the certain cancer immunotherapies, so we have, for example, some patients who are treated with drugs called checkpoint inhibitors. There's a very rare immune complication that can, again, very rarely happen that mimics aplastic anemia and probably is aplastic anemia, where basically the immune system is sort of unleashed by these drugs to treat cancer, but as a side effect, it can sometimes cause autoimmunity. There are also some medications, so you may remember for those who are older or maybe who have lived abroad, there's an antibiotic called chloramphenicol that has been banned for most human use and also for use in animals because of its link to aplastic anemia. Pregnancy, certain viral infections. But again, all of these, even though the list is long, they really are quite rare. And in most cases, we really don't know what caused it. And even if, for example, you say, I have had this, maybe a viral infection right before, we really don't know that the viral infection caused it. It may have, for example, caused some inflammation in the body that sort of really brought this aplastic anemia to life. So what do we think happens in aplastic anemia? So first, conceptually, you think about these stem cells that live in the bone marrow, and we think about those lymphocytes that I mentioned at the beginning of the talk, which are a type of the white blood cell. So these lymphocytes, for whatever reason, are now abnormally activated. And instead of attacking some virus or some mold or some other foreign invader, they now attack the stem cells, in our own stem cells in the bone marrow, leading to aplastic anemia. So you can think of this conceptually that in order to treat aplastic anemia, we need to address two things. So we need to first somehow stop the lymphocytes from attacking the bone marrow. And then secondly, we need to somehow replace the missing stem cells or allow them to regrow. And so the treatments that we do for patients with aplastic anemia really work on addressing both causes. And so there are two main treatments. One is known as immunosuppressive therapy. Sometimes we refer to it as IST. And then the other is bone marrow transplant. Both of these have elements that address the two causes. So in immunosuppressive therapy, we give a medicine called ATG. So this medicine works to destroy these lymphocytes, and then in conjunction with the second medication, cyclosporin, it works to sort of destroy them and then reprogram the ones that are there, that are remaining or that are newly made, to stop them from attacking the bone marrow. In the bone marrow transplant case, every patient who gets a bone marrow transplant also gets immunosuppressive therapy together with sort of in a package of several medications, and they're called conditioning regimens. So it's a conditioning of the bone marrow transplant regimen that now destroys the lymphocytes and stops them from rejecting the transplant. Now, both of these treatment options also address the second key problem. So we need to replace the stem cells that are gone. So in immunosuppressive case, we wait for our own body to regrow the stem cells, basically to expand those stem cells that are still remaining, let them divide a little bit, and hopefully replenish some of the blood production that is now missing. Additionally, the new drug called eltrombopag or Promacta also acts. There's a complicated mechanism, but one of the things that it seems to be doing is also stimulating that stem cell to promote its growth. So basically, it's a two-pronged approach. We hit the lymphocytes with immunosuppression, and then we allow time and potentially this growth factor eltrombopag for the stem cells to regrow. Now, in bone marrow transplant, of course, we come in and we basically put in the new stem cells from the donor. So the recovery in that sense is a little bit faster. So now that, let's say, a patient has been diagnosed with aplastic anemia, and we now know what aplastic anemia is and what elements are needed to help the blood production to recover, we now need to think about how do we approach the treatment. So not everybody is alike. And aplastic anemia also can come in different degrees of severity. So you can think of this as a gradation, sort of starting from non-severe aplastic anemia, when somebody, for example, can have only relatively mild suppression or mild lowering of the blood counts, to very severe aplastic anemia, where someone is essentially needing transfusions for all of their blood production. So they're not really making any of their own blood, or almost none. So, and there are some technical terms. So what I described is the conceptual overview, but there are some technical terms that your doctor may be using to classify aplastic anemia. And these really come from previous clinical trials for us to try to really group patients into more appropriate categories. So for clinical care, we usually think of very severe and severe aplastic anemia as sort of one category as far as the treatment is concerned. But in general, severe aplastic anemia is where we have at least two severely depressed blood lines. So for example, that ANC that I mentioned before, it's that neutrophil count would be less than 500 cells per microliter. Or reticulocytes, those are those baby red cells that I described, that really their low number would suggest that the patient is not making sufficient red cells. So those reticulocytes would be less than 60,000 cells per microliter. And similarly, the platelets would be less than 20,000 cells per microliter. So two of those three would sort of qualify for a diagnosis of severe aplastic anemia. And if that neutrophil count is particularly severe, so for example, the neutrophil count, the ANC is less than 200, then the patient would be called very severe aplastic anemia. And that is because for the neutrophils, it is really, we cannot transfuse neutrophils. We can transfuse red cells, we can transfuse platelets, but if somebody has low neutrophil count, aside from very rare exceptions, the neutrophils, there's nothing that we can really do to effectively restore the neutrophil production here, or sort of to keep the patient safe from infection. Now, for the non-severe aplastic anemia, really there's also quite a range. So it's called non-severe, but in some patients, it's just a matter of semantics. So for example, the patient may still be requiring transfusions, let's say of platelets, but the other blood counts may be just above the cutoff. And therefore, frequently we would manage that patient also as severe aplastic anemia. So this is a good segue to talk about then, how do we manage somebody who doesn't have quite the severe depression of blood counts, and so would be sort of classified as having non-severe disease? Well, here, as I mentioned, it really depends on how much that patient is affected. So for example, if the blood counts are stable, they're not really decreasing, and they're mildly low, so they're abnormal, but perhaps not requiring transfusions. And in general, they were just, let's say, found on a standard blood count evaluation. A patient like that can sometimes be observed with no therapy, as sometimes, right, treatments also have side effects. But certainly that person would need to have very close follow-up to make sure that this disease doesn't worsen. Now, there are those, for example, in whom maybe they started out with mild suppression of the blood counts, but now the blood counts are falling, suggesting that maybe it's becoming a more severe disease. Or for example, they have symptoms. So they are anemic, even though it's not requiring transfusions, but they're still quite fatigued. Or maybe it's somebody who has low platelets, and now, even though it's not quite below the cutoff, but they can't, for example, do something for their job, or they can't play contact sports, etc. So those patients would be treated then frequently with medications to improve the blood count. So for example, some combination of immunosuppressive therapy and then drug, let's say Promacta. Now, there are patients who are sort of on the severe edge of the non-severe disease, so to speak. So let's say they really are requiring transfusions. Well, it would be frequently these patients would be then managed as severe aplastic anemia. So then coming to the severe aplastic anemia therapy. So here would be everybody whose blood counts are really severely suppressed and they are requiring transfusions. So the approach traditionally for managing severe aplastic anemia or very severe aplastic anemia has been guided by two factors. So first, patient's age. Now, I'll mention here, I have a little asterisk by the age of 40. So there's nothing particularly magical about the age of 40, but there are some data that suggest, as I will show you in the next several slides, that patients who are younger tend to do better with transplant. So for patients who are less than the age of 40 or 40-ish, the preferred approach, if there is a matched sibling donor, would be to proceed with the upfront transplant, bone marrow transplant. So then that would be sort of the typical traditional standard decision tree. So somebody who is younger than 40, they have a matched sibling donor, they would proceed to that matched sibling donor bone marrow transplant. And now if they do not have, let's say, the matched sibling donor, or if they're older, they would go to immunosuppressive therapy, generally with the addition of the eltrombopag. Now, in the last now, probably last decade or so, we have really improved some of our management of transplant management. And so patients usually, even if they are, for example, 40 to 50, sort of that middle-aged adult group, can sometimes also have very good outcomes with upfront transplant. So, so for that reason, transplant can be sometimes considered in older patients upfront, but not significantly older, as I will discuss before. Now, for matched sibling donor, previously, the matched sibling donor transplants really had significantly better outcomes compared to matched unrelated donor transplant. However, in the pediatric population, as I will share some of the more recent data, we have evidence that sometimes, again, depending on how quickly the donor is available, how rapidly the transplant can be started, and the general center experience, sometimes matched unrelated donor transplants. Again, this isn't yet standard of care, but in certain centers, you could certainly consider for pediatric patients a matched unrelated donor transplant. Finally, eltrombopag is now really become the standard for upfront therapy. Certainly in adults, it's very beneficial, and there are some additional studies we're sort of trying to tease out just how helpful it is in the pediatric population as well, but it's becoming standard in the upfront care. So I'll discuss now some basic data about these treatment approaches, and I will start with the bone marrow transplant. So just practically speaking, what is the transplant journey like? Frequently, patients think about this sort of like a kidney transplant. You come, you take the organ, you replace it, and you're done, but it's not that simple, because you're basically essentially replacing the immune system. So it's really a long process that can have significant side effects. You can think of this as initially starting with a hospitalization. So I'm putting here about 4 weeks hospitalization. In certain centers, there's sort of a gradation, and some of this is done in what is called like a day hospital, where you basically follow daily. They're in the hospital, but you may be sleeping outside of the hospital. But in most cases, let's just call this hospitalization. So during that period of time, approximately the first, let's say the first week, you're administered chemotherapy drugs. One of them is sort of ATG or chemotherapy or immunosuppressing drugs. And then you may or may not have a dose of radiation that's sort of mixed in right there. Towards the end of this period called the conditioning, you're then given an infusion of bone marrow cells from the donor. And then you just wait, and there's a lot of supportive care and very critical period of time when you're really sort of exposed and very vulnerable to infections when we wait for the blood counts to recover. And then the blood counts recover, usually, let's say about 3 weeks, and then you're discharged from the hospital. You're still discharged from the hospital on a ton of medications that are designed to prevent you from getting various infections in this very critical period of time, as well as medications to prevent something called graft versus host disease, or GVHD. So it's a term for when the donor's immune system can sometimes decide to attack your own body, even though it's matched for several markers, it's not matched for everything. And so it may think that you are a foreign invader and sort of try to attack you. Now, fortunately, in aplastic anemia, it's relatively less common to get severe graft versus host disease because of all of the immunosuppressive therapy that you're getting upfront. So then over the period of months then, so maybe 6 months, there's a taper of immunosuppressive medicines. And then at the end, the goal is to have long-term disease-free survival without complications. So what types of complications some patients can experience? So these could be mild and these could be very life-threatening, including dying from transplant, from complications of transplant. And so some complications could be just the toxicity of that conditioning therapy. So there's ATG, you could still have the same reactions to the ATG. There's organ toxicity that sometimes happens from chemotherapy. Some patients, of course, infection risk is really high. Again, your lymphocytes, the patient's lymphocytes can decide that they want to reject the graft. So this can happen in a small number of patients, maybe about 1 out of 10. And there is the graft versus host disease, which can be frequently managed, but sometimes it becomes a chronic problem. So that's sort of in a nutshell, the bone marrow transplant piece. Now I'll show a few slides of data, just showing some of the numbers that from studies of patients with aplastic anemia. So here is a study of patients who have received matched sibling donor transplant, and that is divided by age. Now, this, I will show you, we are now doing a little bit better than this, but again, this still gives you an idea for why, for example, we choose to do transplant up front for patients who are younger. So just to orient you to the plot, on the x-axis, you see the years of follow-up after transplant. And then on the y-axis, we have the probability of survival. So if the survival is 100%, so if everybody lives, then it would be right stuck up top. But that doesn't happen because, of course, there are all of these potential risks. Now, in these older data, and again, I will show you newer data in a second, but in this older data, pediatric patients, so less than 20, had an 82% survival at 5 years after matched sibling donor transplant. And those patients who were older had only 50% survival. And so traditionally, this was sort of the dividing point. And there are other studies that really confirm this age effect, but certainly patients who are younger were then felt to have a lot of benefit from transplant compared to patients who are older, who may be managed more successfully with immunosuppressive therapy. Now we are doing better. So these are the data from the most recent summary from the Center of International Blood and Marrow Transplant Research. So it's a big organization that monitors transplant outcomes. And so we can see here, for example, on the left side, this was from their summary slide deck, where we have outcomes of patients. Now these are pediatric patients less than 18. And again, same type of plot, 5 years of follow-up. And you can really see that, for example, older transplants, not older patients, but transplants that were done in, let's say, between 2001 and 2005, we have, this is that same line that I showed you before, about 80% survival, but then the survival is really improving with some of the advances in both matching and also the advances in general transplant care. Now, what does it look like, for example, for patients who are over 18? Now, these include some of the older pediatric patients as well as middle-aged adults and older adults. So we see similar trends for this group as well. So for example, in the most recent category, as a group, a very big group, that group of patients are doing better. Now, what if we compare a transplant from a related sibling? So for your matched sibling donor or matched related donor, compare it to, for example, a matched unrelated donor. So for unrelated donors, we have here the matched related donor would be the blue line in both of these graphs, and the matched unrelated donor, so somebody who matched to you in a number of those immune genes, but otherwise somebody from unknown, very kind individual who volunteered to be in the bone marrow registry, who's matched to you. So from these plots, we see that in the pediatric population, really from matched related donor outcomes here, we see very good survival. And even with the unrelated donors, it's a little bit less, but I put here just the line for us as a marker, the 80% line, but still doing really well. With patients who are over 18 years old, the unrelated donor carries more risk, and that risk would be even more pronounced with the when the patient is older. Now, here is a summary for older adults. So basically, this is the summary for transplant outcomes in patients who are older than 40 years of age. And this is from a recent, from the recent EBMT severe aplastic anemia working party analysis published in Blood in 2018. So we see here that overall, the graphs here haven't really changed for transplant outcomes over for transplants that were historically done compared to transplants done now. So this means that even while for younger patients we're improving, for patients who are older, we still need a little bit of work as a field to figure out why it is so difficult to have really good transplant outcomes. And so here are some of the specific statistics. So certainly patients who are 40 to 49, 5-year survival is 67%, 50 to 59, 58%, and it really drops when we talk about 60 and older. And so some of the complications that contribute to this include graft failure. So basically where you put the transplant graft, but it sort of doesn't take or is rejected, or acute graft versus host disease or chronic graft versus host disease. And the numbers are shown here. So one thing that certainly I think matters a lot, and again, this was from the analysis, recent analysis looking at the outcomes of transplant in a center that usually doesn't transplant patients with aplastic anemia, compared to centers who transplant more than 3 patients with aplastic anemia. And we can see that, again, accounting for various other logistics, that the experience does matter. And so certainly, I think going to a center that is a bigger transplant center, and there are many across the United States and across the world, but just asking that whether the center has transplanted patients with aplastic anemia before, and because it really does matter. So if this is possible, absolutely, you should be seen in a bigger center. Now, switching gears to the immunosuppressive therapy. So here is a similar outline to what I showed for transplant, now for immunosuppressive treatment. So what does it look like? So generally, you're still hospitalized for approximately 7 days. Now, the treatment itself involves intravenous administration of this medicine called horse ATG. Or ATG. So this is that anti-thymocyte globulin. It's a medication that is made either in horse, there's another variety that is made in rabbit, and basically it's infused, and that medicine acts to destroy the lymphocytes. Additionally, you're then given a medication called cyclosporin that I think of as putting the brakes on the lymphocyte function. So not all of the lymphocytes will be destroyed by the ATG. Some of the lymphocytes will remain and your body will make new ones. And when those that are remaining and the new ones are made, the cyclosporin impairs the function and prevents that autoimmune attack. Additionally, we have the medicine that I mentioned called eltrombopag, and I will discuss some data on the addition of eltrombopag from the recent NIH study. So you're admitted to the hospital, you stay there. Over approximately 4 days that ATG is administered, but frequently you may have fevers, for example, due to the ATG, or allergic reactions, or in general may have various lab abnormalities, and sort of the hospitalization may not finish right as soon as the medicine is done. And so usually it takes a few days to really make sure everything is in order for you to go home. When you leave the hospital, you're still on a number of medications, which actually are rather similar to the ones that you would leave the hospital after transplant. So you would be on cyclosporin as well as the eltrombopag. So these are oral medicines that you will stay on for some time. There are medicines to prevent a complication of sort of immune complication of ATG called serum sickness. So that medicine would be steroids. If you've ever, for example, had poison ivy, or you know somebody who has asthma and they've taken prednisone, well, so you would be on prednisone for about 2 weeks after the hospital stay. And then frequently you're also on a number of medications to prevent infection. So once you then leave the hospital, the first few weeks you're sort of adjusting to all of the medications and schedules, but after that it sort of becomes a little more routine. The eltrombopag generally is continued for about 6 months, and then after that it's either weaned off or stopped. And then the cyclosporin medication continued for about 2 years. Again, sometimes the taper may take a little longer. Over the initial period of time, you still need transfusions. And then the blood count improvement takes about 3 to 6 months. So I will show it to you. So that's sort of one key difference. With transplant, you get the conditioning that suppresses the immune system, then you get your new stem cells replaced from the donor. So you leave the hospital, and generally, you may not need transfusions for much longer, if at all. With immunosuppressive therapy, you get less toxicity up front from the transplant, but then you need to wait for your own body to produce those stem cells. And so that's going to take 3 to 6 months. So some of the complications from immunosuppressive therapy, you could have an allergic reaction, for example, to ATG. As I mentioned, you're monitored quite closely, fever or rash from the ATG, or serum sickness. Again, that's the same medicine that you would also have been getting with transplant. Side effects of medications, really here, what I think is the biggest, as two biggest differences are that it takes really long time for you to get the blood counts back, and you get transfusions along the line, and then there may be a period that you may still be neutropenic for quite some time. And so the risk of infection is really the biggest, the biggest danger. And then also because you still have your own stem cells that are regrowing, sometimes those stem cells get stressed and sort of trying to survive, and they may develop something called long-term complications of something known as clonal evolution, or sort of sometimes development of mutations that may lead to MDS. So that may happen in about 15% of patients. Okay, now a little bit of data about, and sort of the numbers, specific numbers from these treatments. So this was from the pivotal trial from the NIH group that added eltrombopag. So this medicine, the brand name is called Promacta, the generic is eltrombopag. So added eltrombopag to the standard immunosuppression therapy of ATG and cyclosporin. So there's sort of the trial was complicated as far as how it was structured, but I'm putting here basically the bottom line. So when we take the bottom line for all patients who were on this study, after 3 months, we see that there was 80% total response rate. So this counts anybody who's improved blood counts or those who completely improved them and sort of almost normalized them. But basically 8 out of 10 patients on the study had improvement at 3 months, and 87%, again, of all patients on the study had improvement after 6 months. So when you can see how this happens. So this is a graph where they plotted basically how long does it take for someone to improve the blood counts. And we can see, so this would be at baseline, and then 3 months, and then 6 months from that study. And we'll just focus on this blue line, which is with the addition of the L-Trombopag. And we can see that really, you can see sort of that curve of the blood count improvement, that really most of the improvement probably occurs before or by 3 months, but you still have a lot of improvement that here, for example, happens between 3 and 6 months. So it does take that long, because frequently, I think we get through the immunosuppressive therapy and you still need transfusions a month out and you wonder what's going on. Well, you're still really early. So, right, so you can see what happens after 1 month. It's still very early. So we need to get to that 3 months mark, 6 month mark and sort of it's a marathon like treatment. Now, but comparing here, you can see that just with the immunosuppression, so before adding the Promacta or L-Trombopag into the therapy, we saw that the improvements were less pronounced. So certainly the addition of L-Trombopag does speed things up, particularly for the platelets, but interestingly also for the neutrophils. And really you can see that it does truly improve the disease. So you can see this was the graph of the patient's bone marrow biopsy. And if you recall from the beginning of my talk, where I showed you side by side, the normal bone marrow where we see sort of those white areas that are those fat cells, and then we see that purple area, and so the purple area are the stem cells. So this is, for example, a bone marrow biopsy of somebody who started the treatment. You can see it's all white here. We don't see much of the stem cells, but not much of that purple area. And this corresponds to about 20% or less cellularity. So they plotted here the number of cells, and you can see that in these patients, I guess, this little crosshair is approximately, less than 10%. Now, if we look now at patients who have gone through this treatment and we look at their bone marrow, look, all of the white areas are sort of, again, this is not the exact section, but they sort of receding. And on average, you see a lot more stem cells. And again, you see more stem cells here at 6 months. And this corresponds to just numerically trying to quantify it, that you do have more cells. So it's possible with immune suppression to recover the bone marrow, to have a complete remission, and sort of for this to be the definitive treatment. Now, this here is a historical study, now also from the NIH group. This was from 2011, where this was a pivotal trial that compared 2 different types of ATG. So that there's this ATG immunosuppressive therapy that I mentioned is made in horse, and the other that is made in rabbit. And there are various logistics for why, in certain areas of the world, for example, the horse may not be as readily available. And unfortunately, the rabbit is sort of the one medication that sometimes people have access to. And it also works. But the comparison here was of patients who were randomized to receive either rabbit or horse ATG to compare whether these medications lead to the same effect. And here again, I will sort of distill it in the table, where at 3 months with horse ATG, we had 62% of total response rate, and it was 68% after 6 months. So basically it means, so without L-Trombopag, we are at about 2/3 responses, so at about 68, about 70%. With L-Trombopag, at 6 months, that number goes higher, so it's approaching somewhere around 80%. Some of that, again, may not be necessarily long-lasting, but the key benefit is that it's in this vulnerable period where you're really prone to complications like bleeding or infections. Improving the blood count sooner does make a difference, even if some of that, the total height or sort of the peak of the blood counts may not quite last that long. But in general, anyway, so here we see that the horse ATG is better than rabbit ATG. With rabbit ATG, the responses were just over 35%, so 37%. And you can see that the survival here, so this was the curve where they looked over the period of time on the x-axis, and then you see the survival curve on the y-axis. And the blue curve with the horse ATG, so patients who got horse ATG, more of them were alive as compared to those, slight decrease, but very meaningful difference between the horse and the rabbit. So now moving on to the final few pieces of information. So one question that frequently comes up is how long to continue to take cyclosporin. So it's not uncommon, for example, for somebody to have received ATG, cyclosporin, Promacta, and actually achieve pretty good blood counts and everything is looking great. And there is a tendency to want to stop the cyclosporin because of some of the nuisance type side effects. So sometimes it may cause a tremor or elevate the blood pressure or just cause some side effects for patients. And so there's a sort of this urge, I think, to stop it early. But we can see from the study, this was the study from the NIH, where they had a group of patients where cyclosporin was discontinued at 6 months. Now, in this case, the graph shows probability of relapse. So if you did not relapse, you would be here at 0. And if somebody relapsed, the curve goes up. And so in patients who discontinued cyclosporin at 6 months, nearly 50% of patients relapsed. In contrast to a significantly more prolonged and more lasting responses with cyclosporin. So it's essential that the cyclosporin maintenance is continued for at least 2 years, which was what was on the study. And in general, it's very important if you're lowering the cyclosporin to monitor, because you can very frequently just salvage or sort of achieve a second remission by just increasing the cyclosporin dose or resuming Altrombopag if that was also a part of something that was stopped. So again, cyclosporin is essential for maintaining the durability of remission. It doesn't fully prevent relapses, and it's possible that it's delaying the relapse. But again, frequently with judicious taper and then close follow-up, you may be able to sort of stave off a full-blown relapse and the need for a full retreatment if you sort of catch that relapse early and sometimes just resume cyclosporin or Altrombopag. Okay, so now we're at the end of my presentation. So what happens after? So you're now on the other side and the blood counts have improved and you're in some sort of a stable and either very good partial remission or in complete remission, no longer need transfusions, and are either close to being tapered off the medicines or completely off medication. So for patients who have been treated with immunosuppressive therapy, generally it's still very important to have blood count follow-up. So you should see your hematologist periodically, or for example, if you have a very good partnership with your primary care doctor, they can also monitor the blood counts closely, knowing that you may develop certain types of complications in the long term. There is a possibility of relapse, although it would be a little bit less typical to relapse after a very long, prolonged remission. Usually the relapses sort of happen towards the end of the taper of cyclosporin, but nonetheless, it's important to monitor for blood count stability. Sometimes patients may evolve to that MDS that I mentioned, myelodysplastic syndrome, which is a type of blood cancer. Generally, it depends on also the duration of the disease, how old you were when you developed aplastic anemia, but somewhere on the order of about 15% of patients may develop myelodysplastic syndrome. And then some patients also may develop a disease called PNH, so paroxysmal nocturnal hemoglobinuria. So in this disease, there's also a mutation that happens, and patients develop anemia, and it's called a hemolytic anemia, where the blood cells sort of a little bit less hardy, and they can break up and they can cause anemia. They can also cause blood clots. So in general, the follow-up is certainly needed, although most patients don't develop these complications. Now, after bone marrow transplant, you also need follow-up. So certain types of preventative care that would be done at your transplant center or in a survivorship program. So some of these may be related to, for example, receiving another course of all of the immunizations for your new immune system, certain types of preventative screenings, for example, bone density and making sure vitamins and all of that stuff. So, so overall, I think, I guess I want to leave you with a message of hope. I think aplastic anemia is a very severe and very bad diagnosis that is ultimately highly treatable, frequently curable, and we are now improving our ability to care for patients with aplastic anemia. And I think the key is to be sure that everything is done thoughtfully, and generally, I would absolutely urge you to make sure that you also, if you're being treated locally in a smaller center, that you also have sort of as a backup, maybe a consultant at one of the larger centers nearby who can help direct your care. Okay, thank you very much. That's all I have.
Thank you, Dr. Babushok. We have a few questions. This one is a woman is submitting on her 20-year-old daughter with aplastic anemia. She was diagnosed in 2017 and has developed painful splenomegaly. And just a note also, this daughter was adopted at age 2 from China. There is no family history. Genetic testing revealed she is a carrier of Fanconi anemia, but doesn't have it. And also abdominal varices, if I'm using that term correctly, were discovered in CT scan. Are either or both seen in aplastic anemia, the splenomegaly and the abdominal varices, if I'm using that term correctly?
So, yeah, so I'm sorry to hear about the troubles from of your daughter. So in general, these are not a feature of standard aplastic anemia. So this really speaks to me that something else is likely going on. So painful splenomegaly and abdominal varices suggest that either there is maybe liver disease or some kind of a blockage, maybe either a chronic blood vessel blockage or basically chronic buildup of the pressure inside of the blood vessels in that abdominal system. So that can lead to enlargement and sort of pain in the spleen, and also can lead to the varices, which are basically like the outpouchings of the blood vessels. I'm sure that, or I hope that your daughter is getting care. It sounds like it's a, complicated case. And I think looking into sort of just the state of the liver, as I'm sure that they are evaluating, but it's not something that that would be common in aplastic anemia or seen in aplastic anemia. So it's not a part of aplastic anemia, and does suggest that there's either a second process that's related to the liver, or maybe one underlying process that sort of unifies everything. I guess one thing that comes to mind, and again, I don't know that this is something related to your daughter at all, as it sounds like she has been evaluated for genetic causes of marrow failure, certain types of inherited telomere conditions. So telomere is a end of the chromosomes, and some of patients who have shorter telomeres or genetic defects in telomeres can have sometimes liver cirrhosis, for example. But again, it's a little bit hard to say. And when you have many complicated things that are happening that suggest that this is a chronic issue. So for example, the varices suggest that it's a chronic issue. It's sometimes hard to know what started first. Was it the liver issue that sort of then precipitated all of that, and the blood counts are low because of the liver problems, or whether there's something underlying? But so best of luck to you and your daughter.
Thank you. Another question: is prednisone used to boost hemoglobin or platelets blood counts in lieu of L-Trombopag? This would be after a successful horse ATG with cyclosporin.
So no. So it's a great question. It's so prednisone in the setting of immunosuppression with ATG is used to treat an immune side effect of ATG. So ATG are basically little things like antibodies that are made, let's say in the horse, and they lyse the lymphocytes, and they can cause little clumps and basically lodge sometimes, like these antibody fragments with cells called immune complexes can cause a rash and painful joint pain, basically, after ATG. And the prednisone is given to treat and prevent that complication. So usually it comes as a package. So meaning the treatment comes as ATG, and with the ATG, you get the prednisone for a period of several weeks to cover for that period when patients virtually, if you don't give prednisone, they would virtually all develop this, just a painful, unpleasant complication of ATG. The prednisone itself does not really boost the stem cell production, and it actually has some side effects. So major side effects, like with long-term prednisone use, patients may develop, for example, diabetes, moodiness, inability to sleep, and be prone to infections even more so than before. So we usually don't use prednisone like long-term instead of L-trombopag in this setting. There are certain other conditions, again, not aplastic anemia, where prednisone is used. So for example, in something called ITP, which sometimes patients may think that they have, that they make platelets, but the platelets are later destroyed. Steroids are used in that setting, but again, not to boost the stem cell production, but to stop destruction of platelets due to in that other disease. And then there are other settings, for example, other bone marrow failure conditions like Diamond-Blackfan anemia, where we can use the steroids to boost stem cells in that particular disease. But the bottom line is no, in aplastic anemia, steroids are a temporary fix to manage the side effects of ATG.
Thank you. Another question. How can you tell if PNH is attacking stem cells or aplastic anemia?
Perfect. So PNH, it's interesting. PNH is, so PNH does not attack stem cells or aplastic anemia, but it is sort of it's a little bit complicated to explain. So in aplastic anemia, as I mentioned, we have the stem cells in the bone marrow, we have the lymphocytes, and the lymphocytes are attacking the stem cell. Sometimes in that stem cell, when the stem cell is trying to escape from the attack, it's trying to do something. So occasionally there are genetic changes in that stem cell that all of a sudden make it sort of almost like it's invisible, or it's immune to the attack by the lymphocyte. And PNH is one such circumstance. So it's not precisely known why it happens, but if there is a genetic mutation in the stem cell that causes the PNH, so what does it mean? Basically, there's a mutation that makes that stem cell lose some of its cell surface proteins, or like little antennas on the surface, and that stem cell becomes a little bit less visible to the lymphocyte. So while the normal stem cells just die, the stem cell, the PNH stem cell, is a little hardier in the bone marrow of an aplastic anemia patient, and it survives. In some patients, this PNH stem cell does really well, and then it sort of multiplies, and it now starts, your blood production essentially would come in patients from PNH. So there are patients who have almost all of their blood production coming from PNH stem cells, because they presumably outlived the other cells, and they now are able to sort of escape that immune attack, and they live. Now, is it bad to have PNH stem cells? Well, so they make blood. It's a blessing in some way. On the other hand, the red cells that are made from that stem cell, the ones that make you carry oxygen and give you strength, those red cells are not as robust as normal red cells because they're missing some of these cell surface antennas. For whatever reason, they are more likely to break in the blood in a process called sort of this complement activation. And so there's complement, which is part of the immune system that activates on the surface of the red cells and makes them break open. So to sum up in simple terms, the PNH itself doesn't attack anything. It's basically, it's caused by a genetic mutation in the stem cell that typically comes in association with aplastic anemia, right? So in aplastic anemia, we have an immune attack. PNH stem cell is more immune to that immune attack. PNH stem cell can make blood cells. It makes nearly normal neutrophils. It makes red cells. It makes platelets, and it can restore blood count. So it's frequently, in fact, used as a marker, as I mentioned at the beginning. If you find a little bit of PNH cells, probably you can conclude that the person's bone marrow failure is caused by an autoimmune attack because the PNH cells are just so tightly linked typically to this immune-mediated marrow failure. But the PNH red cells break open and cause this hemolysis. And so there are many new drugs and a lot of new developments happening for patients with PNH, which is very exciting time for PNH patients and to be in the PNH field because we now have medications that so effectively can treat full-blown PNH disease if it happens, meaning that if nearly all of the blood production starts coming from that PNH cell. So it's a complicated topic that probably, I'm sure the AAMDS Foundation has a whole session devoted to the PNH also.
Yes, we do. Later today during our conference, we do have a session on PNH. Here's another question. This person will be 70 years old soon, had horse ATG in 2016, cyclosporin until 2020, and L-Trombopag until 2019. Recently diagnosed with relapsing aplastic anemia. Doctors want them to do a second round of horse ATG, but they had terrible side effects first go round, and they're frightened about having the second.
It's a difficult situation, especially in that age group. So, and I can't advise, very specifically for this case, but I can more generally speak to what typically I would recommend or we do in cases of relapse. So, in good news, when someone with aplastic anemia responds to immunosuppression, and I hope and I presume that there was good response, whether it was a good partial response or complete response. So, and the blood counts improved. If a person has previously responded, they're also more likely to respond the second time. So that is, I guess, one piece of information that I find helpful, that prior response to this type of regimen does predict second response. Sometimes, depending on how, just how fit or in what general shape of health the patient is, the ATG may or may not be perfectly suitable. So we do know with ATG, you would have, in general, a more chances of getting good response faster than if you, for example, another alternative would be to, let's say, do full dose cyclosporin in combination with L-Trombopag together, but that combination may take very long to work, right? So if you add that ATG for the retreatment, probably I would expect that there's a 2/3 chance, if not better, for the patient to respond the second time with ATG. Now, with just cyclosporin and L-Trombopag, I don't have the specific sort of number to give, but I would expect it would be somewhere on the order of between 30 and 60%, sort of in that middle range. And again, it's sort of, again, it depends on everything else. Also, such that what, for example, what was the first response and how low the blood counts are now and what the bone marrow looks like at this time, and if there's any other complicating factors like mutations, etc. But basically, the options are, retreatment with ATG. I personally do like horse ATG, of course, compared to rabbit ATG. First, we have the data that horse is a little bit superior up front. It also is less immunosuppressive, paradoxically. So the lymphocyte counts recover a little bit faster. There is some, there's some data that the second time retreatment, the allergic reaction risk may be higher with the horse. So people have certainly done that, but sometimes there's a risk of allergic reaction. So rabbit is frequently substituted on the second retreatment. But rabbit may be a little less effective, but also more immunosuppressive in the long term. So anyway, so retreatment with ATG in combination with cyclosporin and Promacta, I think is very standard and probably the most effective option. So the second option, if, for example, a patient cannot tolerate the second go round of ATG, or for whatever reason, or for example, if their blood counts are not quite as low and maybe having a longer time to respond is acceptable, in that case, you could try full dose cyclosporin together with the eltrombopag also. And that may, over a period of time, I would give it certainly 3 months to determine if that works. I hope this helps.
Thank you, Dr. Babushok. We'll have one final question here. This is a 21-year-old from Italy, and thanks you very much for the presentation today. The question is, why are age classes so wide? Excuse me. I would imagine a 20-year-old reacts differently from a 40-year-old, correct? Total response is not, I'm sorry, one more statement here. Total response is not cure. The 36% is really low. Do you wait to go for a transplant?
So let me try to sort of say back the question to make sure I'm fully getting all of the parts. So, so the question was, there's somebody who is 21 years old, right? And
yes,
then
yes.
They were treated with immunosuppression. The question was, why are the age brackets so wide? That was question
Yes.
one. And the second question is, presumably, I guess the discussion is about rabbit ATG. Is that right? And then why is the response 36%? Is that, am I understanding the question?
Yes, it's they would imagine that a 20-year-old reacts differently from a 40-year-old, and total response is not a cure. 36% is really low. So do you wait or go for transplant?
So, okay, so it's true. So first, just to address the age bracket question, yes, the age brackets are very broad. In someone who is, let's say, in their 20s, if you have a matched sibling donor, or if somebody, let's say, is in their 30s or 40, they have a matched sibling donor, the optimal treatment would be to go for transplant if that is feasible. If somebody is younger, let's say pediatric age, so 21 is sort of on the border. In certain centers, and this is not yet standard, but as I've shown just the curves, for example, for matched related transplant compared to matched unrelated transplant, our outcomes in pediatric patients with matched unrelated transplants are really coming along. And now they are as good with unrelated as they used to be 20 years ago with related. So sometimes, again, to find an unrelated donor, it takes time. to identify perfectly matched unrelated donor, line up the date for the transplant, do all of the testing. We try to do better, but in general, it takes months. So, if you have a center that can mobilize everything, and by luck, you're able to get this matched unrelated donor from a registry quickly, it's possible that in the pediatric group, maybe an unrelated transplant upfront may be a preferred option. But again, this is sort of a not standard, and the area is evolving. But this is generally what the experts in the field think, is that with unrelated transplant, if it can be mobilized quickly in a young patient, that could sometimes be the preferred option. Now, if you don't have the donor sort of optimally mobilized, let's say somebody comes to me, they're 21, they don't have a matched sibling donor. What I frequently discuss is that what I would do is I would initiate this unrelated search, but to really fully know, to really fully be in a position to even consider unrelated transplant, we are several months out. But we have really good outcomes here with immunosuppressive therapy. Now, for the rabbit ATG, it's a little bit different, and rabbit is frequently what is available, for example, in Europe or in several other places. So certainly I would be very, I would have a very low threshold to move forward. If there's no response, I would move forward with the unrelated transplant quickly as an option. And if it's something that can be available sooner, I think comparing, we are in the US frequently comparing the horse ATG, where the horse ATG responses are quite a bit higher. If there's no good access to horse ATG and you're looking at really 30-some% response, then I think unrelated would be a very reasonable choice.
And here is a brief follow-up to that from the same patient. They're doing rabbit ATG, cyclosporine, eltrombopag, and all sorts of other supportive therapies. Is there a moment when, with immunosuppressive therapy, you can say, okay, I'm cured, and while doing 2 years of cyclosporine, can you go back to a previously, a normal COVID-less life?
So I think in general, I would wait 3 to 6 months for those responses, right? So after, and perhaps some patients continue to improve, although it does seem that the responses sort of plateau after 6 months. So let's say this patient is treated and they are doing better, meaning that they don't need transfusions, let's say 2 or 3 months after therapy. So they don't need transfusions anymore. And the blood counts are coming up, and the patient is not neutropenic any longer, and is not suffering infections. So after that, we proceed. Once the blood counts sort of plateau and stabilize at some range, we now think about, so what is good enough? We are blessed, all of us, by being born with too many more blood cells than we need for normal life. So for example, we don't need, let's say, 150,000 per microliter platelets to be safe, right? So we need somewhere around 100 would be nice. 50 to 100 is safe for most surgeries, etc. Similar for the hemoglobin and the red cells, it would be nice for everybody to have a hemoglobin of 13 or 14, but frequently, a hemoglobin of 10, 11, 12 is sufficient to feel well, to be active, to have energy and do pretty much any activity. And then for the white blood cells, again, as long as you are not in the severely neutropenic range, you usually have the immune system that can protect us from infection. So in general, I frequently tell my patients not to strive for something that, on the printout that the doctor gives you says normal. I think we are striving not for perfection, but we want good, safe number of blood counts that are stable, that they're not going to fall with the relapse. So I think in general, yes, you can be cured with immunosuppressive therapy. There are many caveats, but in general, you can certainly achieve very good responses. With rapid IgG, it's a little trickier because the responses are a little less and it's a little more immunosuppressive. So I think if, for example, let's say 3 or 6 months down the line, there's no improvement, and sooner even, if the neutrophil count is low, right? If this, the one really the Achilles heel of immunosuppressive therapy is this long period of time for the response that it takes for somebody to respond. And we may transfuse the red cells, we may transfuse the platelets and give antibiotics, but if that neutrophil count is really, really low, and if it's not budging, I would be pretty fast to try to be seen at a transplant center just to line it up as a backup option. So in general, I guess if I'm treating somebody with immunosuppressive therapy, I usually always think of the plan B and the plan C. So yes, we are going for immunosuppression, but at the same time, behind the scenes, we are sort of mobilizing, well, other donors, where are the donors? And sort of what else do we need? Should we need to move forward, let's say 3 or 6, let's say 6 months down the line after immunosuppressive treatment?
Thank you so much, Dr. Babushok, for sharing your time and expertise with us. If you would like to watch this session again at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform hub. If we were not able to answer your question today, you can send it to us at any time in 3 ways. You can send an email to help@aamds.org. You can call the AAMDSIF helpline at 800-747-2820, extension 2, or you can submit a question on our Facebook page. Be sure to visit the exhibit hall, and the next educational session will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 37 years. This concludes the session.